So how do you prepare for a case in surgery? Does it matter if you're a student or an intern or a junior or a senior resident or a fellow or even attending? Well, I'm going to tell you that it does. The preparation is different. Today I'm going to teach you how you can prepare no matter what level of surgery you're in, whether you're an intern or you're an attending. Let's do it. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson. I'm a pediatric surgeon, and I'm here to scale surgical education, get you comfortable in the operating room, in the wards, in the ICU, and of course, to crush your exams. Today, we're going to do something just a little bit different because we're going to be talking about how to prepare for cases. A bunch of you have reached out in the comments and have asked, so how do you do it? How do you prepare? How can I go in and crush it and get the most educational value out of that operation, all right? And so today I'm going to go through whether you're a student or a junior resident or an intern, whether you're a senior resident or fellow, and then I'm also going to share how I prepare for cases, okay? And at each level, it's different. As the attending surgeon, I have different expectations when I have a student with me. Okay, I don't expect a student to tell me the technical details of how to get a little bit more length for a long gap esophageal atresia, okay? Or I don't expect the student to tell me how I can get more length on that LAR, how I can get that to reach without tension, or tell me how I can do a biliary anastomosis. Okay, those are beyond the student's kind of scope of knowledge and expectations. I would expect that of a senior resident, but not of a student. So I'm going to tell you kind of my expectations in the operating room with the residents that I train and how you can set yourself up for success. So let's start out with a case. Let's say that you have a newborn, has a prenatal diagnosis of polyhydramnios, and otherwise was a normal, very healthy pregnancy, is born and cannot tolerate any feeds, just pukes everything up, okay? And this is like day of life number 2. Okay, you get an x-ray and it shows this. What does that show? All right, so this is the double bubble sign, and this is consistent with duodenal atresia. Okay, so you make a diagnosis of duodenal atresia, the attending books the case for that afternoon or the next day in the operating room, and now let's say you're a student and you want to prepare for this. What are you going to do? What are you going to read? All right. So let's get into it. If you're a student, how do you prepare for a surgical case? So for the student, there are 2 big questions, 2 big goals, okay? And that is number 1, who, and number 2, what? All right, so the who is the patient. Remember, when you're a student, you have your textbooks and you have all this stuff to read, but the real gold is in the hospital. The real gold is taking that history, doing an examination, going through all the labs, going through all the imaging, not just reading the reports, looking at the x-rays, looking at the CT scans, looking at the contrast studies if you have them, and forming that differential. So you have to know the who. In this case, if I was a student, I'd be diving into that prenatal history. Oh, so when does polyhydramnios develop in the setting of duodenal atresia? Or what are the immediate postnatal findings? Well, how is that different from, say, a malrovolvulus or a tracheoesophageal fistula? What are the different things that are happening in that immediate postnatal setting? Okay, so you really want to dive in and understand the who. And as the attending, when you come into the case, my expectation is that you know the who cold, because that's where the goal is, and that's the very beginning of the ladder. And if you don't take time to understand your patients, and you don't take time to learn who that patient is and why they might be presenting with this particular problem, then knowing all the technical jargon and all the surgical subtleties isn't going to make a difference, because you're not going to really get that solid foundation, that solid infrastructure. So first is the who. Know absolutely everything about the who. And second is the what, okay? So what operation are we doing for what pathology? What is the anatomy going to be? You just have to have a simple understanding of the anatomy, and in this case, for this patient, the embryology, okay? So in duodenal atresia, you're gonna wanna understand, well, what are the anatomical relations of the duodenum to the stomach and the pancreas? What's sitting behind there? So we have the inferior vena cava, we're gonna have the kidney, the adrenal gland, we're gonna lift that up. What are those anatomical relationships? One of the things that's really important in anatomy is understanding those relationships. So if you're preparing for any operation, whether it's an LAR for a rectal cancer, or it's a laparoscopic cholecystectomy, or it's a laparoscopic appendectomy for appendicitis, understand those relationships. And if you understand what those surgical relationships are, you'll have a really good understanding of what the risks of surgery are. So when we're talking about a laparoscopic cholecystectomy, if you understand that you have the gallbladder and the cystic duct or the common bile duct, and you could possibly injure the common bile duct, or you could possibly injure an hepatic artery. The duodenum is right there, the liver is right there. So if you have that solid anatomical foundation, when you decide to choose a career in surgery and you're advancing up, now you'll understand, oh, this technical maneuver allows me to get greater exposure because I understand the anatomy, or I can reduce this risk of a common bile duct injury if I perform this particular maneuver, engage in this type of technique. Okay, so anatomy is everything. So the what as a student is understanding the anatomy and then understanding the pathology. And you just have to have a basic understanding of this. The bonus, and I discovered this when I went on sub-Is or when I was on more advanced kind of rotations as a student, it's a bonus if you understand the history. So if you're in an operation, let's say you're doing a laparoscopic Nissen fundoplication or a robotic fundoplication, it's good to understand, well, who was Rudolf Nissen? Okay, who was Toupet? Why is the Belzy Mark IV named the Belzy Mark IV? Who was Dorr? Who was Hill? You know, all these different fundoplications, understanding the history, and there's lots of great like free literature out there that you can read. And to the attending, it just shows that you have an authentic interest in surgery, okay? So think about that. You gotta know the who, you gotta know the what, simply, okay? Simple anatomy, simple pathology, and if you want the bonus, dive into history. I did a really good video talking about my favorite surgery books. I did another one of my favorite anatomy books, but here are some books that if I was a student in surgery, I'd wanna start with to understand that what. And the first is anatomy. So you have to have a good anatomy textbook. So that would be Moore's Clinically Oriented Anatomy. That's my favorite anatomy textbook, okay? You also have to have that anatomical atlas. So if you're doing any abdominal operation and you want to know relationships, you can go through all the plates and netter and have a really solid understanding of what are the anterior, posterior, superior, inferior, medial, lateral relationships of, let's say, the head of the pancreas. You know, what vessels are close, what organs are close, what nerves are close. So then you're going to understand, well, this is why an attending is concerned about a particular risk, or this is how a cancer might invade a particular structure. Got to know those anatomical relationships. And the third is a basic surgical textbook to understand the pathology. I think Schwartz is a really nice one when it comes to using simple language and getting into straightforward surgical pathology without getting too far into the weeds. So if you're looking for one of the major textbooks to read as a student, I would say that Schwartz is a really good start. So let's say that you have decided that you're going to be a surgeon. You apply for the match, you match into a general surgery program, you're an intern, you're working your tail off, and now you're on the pediatric surgery service. You have this duodenal atresia case the next day. What do you read? How do you prepare? Okay, so you got to have at least the same things as the student. You got to know the who, absolutely. All right, you have to know the what, maybe a little bit more detailed, but not crazy, all right? And you have to know the why. The difference between the expectations of the student and the intern, for me, are, does the intern know why we're in the operating room? Does the intern know why we're in the operating room now and not a couple of weeks from now or not yesterday? So the why is really important, and it's a foundational concept in your growth as a surgeon. You always have to be asking yourself, why are we doing this operation? Why are we doing it at this particular time frame? Okay. And if we look at, well, what are the resources that are good for the intern? For me, they're the same as the student. You got to review that Moore's anatomy. You got to review Netter's anatomy. You really have to understand those relationships, and then complete reading the textbook. Read it cover to cover when it comes to Schwartz. Okay. And if you get that first textbook under your belt, then you can move on to the next one. I'll do a quick aside. So what is a good reading strategy? There are basically two pathways that you want to have as an intern in a resident surgery. The first is you want to read for the specifics of that rotation. Okay, so let's say you're on colorectal, or let's say you're on pediatric surgery, or cardiothoracic surgery, or the general surgery, or trauma surgery service. You have to read for what's going on there, right? But you have to have this other pathway where you're reading to get all of those other subjects in that you're not going to rotate on. My personal preference is that you take a textbook and you just read it cover to cover. And the way that I did it is I would set up my desk and I would set up my textbook the night before, and I would set up a stopwatch, and I read for 30 minutes every day. The magic time for me was between 4 and 4:30 in the morning. I would set my coffee pot, come on at 4 o'clock, sit down at my desk. I'd be reading for 30 minutes, okay? The clock would go off, and then I'd get up, shower, get changed, and go in, maybe get a workout in, but usually just go into the hospital around 5. And so when I was reading cover to cover, I just left the textbook open on my desk, and every day I just went as far as I could in 30 minutes. So now if I'm a junior resident on the general surgery service, let's say I'm a PGY 2, PGY 3, I'm going to have to know the who, all right? That's foundational the whole time, from student all the way up to being an attending, all right? So you have to know the who. You have to know the what, and now you're going to have to get into more of a detailed what. So a really solid understanding of the anatomy and a really solid understanding of the pathology, okay? You got to know the why, all right? And in addition, you're going to start learning the how, okay? And the how are the technical aspects of how you do an operation, okay? And I'm going to get into how I think about operations here in just a minute, but you'll want to start engaging in not only a more advanced surgical textbook that talks about technical concepts and kind of a how to do an operation, but also invest in a surgical atlas, something here like Zollinger's or Mastery of Surgery. And that way you'll be able to kind of see through an illustrated way how an operation is done. Zollinger's is incredible. All of the plates are just absolutely beautiful. And then if you combine that with a Mastery of Surgery, you're able to kind of read that text. I mean, check out the hernia chapters in Mastery of Surgery, and you're going to get a dissertation on all of the technical principles of inguinal hernia. You're going to go through Bassini, you're going to go through the Coopers, you're going to go through the McVeigh, you're going to go through laparoscopic, robotic. You're going to get the technical details of all of those, and then side by side, you can be reading in that with Zollinger's and get a solid foundation on the how an operation is done. And so when I'm with a junior resident, let's say a PGY2, the questions I'm asking them are, so how are you going to set up this case? What are you worried about? How are, for example, a duodenal atresia, what are you going to have to do to expose the duodenum? All right. What is going to make that easier? So if you combine your reading of Mastery of Surgery, or in this case, an operative pediatric textbook with a surgical atlas, you'll really start to build that solid how foundation. So let's get into that how, all right? And There are a couple of schools of thought, and I'm going to give you my honest opinion on how I approach operations. So first is you can think in steps, okay? Step 1, step 2, step 3, and that might be easy to memorize. If you have a real long operation like a Whipple operation, there's going to be like thousands of steps, and so that can be difficult, all right? If you have a laparoscopic appendectomy, perhaps it's a little bit easier. But the problem is that if you think in terms of steps, what if all of a sudden you get to step 3 and it says make a window at the base of the appendix of the mesentery so you can divide the appendix? What if you can't get to the base? What if it's so socked in, or the mesentery is really like tight down on that, the pelvic brim? What do you do then? You can't get to step 3, right? So then you get into these weird like, okay, option B, can't get there. I think about it a little bit differently. I think about surgery as a story, okay? Every story has a beginning, a middle, and an end, all right? So you have the beginning of an operation. Well, the beginning of the operation is the setup. Let's say it's a laparoscopic appendectomy. Well, you're going to want to expose the abdomen, all right? You're going to have to choose what your trocars are going to be if it's laparoscopic. If it's open, you're going to have to choose what incision you're going to make, okay? Are you going to make an angled incision? Are you going to make a gridiron incision? How are you going to approach the appendix, okay? And that setup, patient positioning, trocar placement or incision placement, that's the beginning of the story, all right? Second is the middle of the story. Well, the middle of the story is accomplishing your goal. So in a appendectomy, your goal is getting the appendix out. So for me, once I get my trocars in, I position the patient right side up, head down, I'm looking for the appendix, I identify it, I then say, okay, I got to get the appendix out. Is it easier for me to just take the mesentery with electrocautery, or is it easy to see the base, make a mesenteric window, divide the base of the appendix, and then take the mesentery either with electrocautery or a stapling device, okay? So if you start thinking about operations in terms of a story, and that middle part is accomplishing your goal, then if anything happens, you're not stuck on, oh man, what was step 4 or what was step 7? I don't know. You just know what you have to do, and then you can adapt. And then you get to the end of the story. So how are you going to close the wound? Are you going to leave a drain or not? Where does the patient go? Do they go to the PACU or do they go to the ICU? Are you leaving the Foley catheter, and are you leaving the nasogastric tube? So all of those things are kind of the end of the story, all right? So my how is thinking of surgery in terms of a story, that every surgery has a beginning, a middle, and an end. If you think like that, the operations will be a little bit less intimidating because you're not memorizing all these steps. You're just kind of breaking it into chapters, I guess. All right? So try that, see how it works, let me know. So let's get to the senior resident or the fellow, okay? So how does a senior resident or a fellow prepare for a case? So number one, they know the who, right? They have an absolute and detailed understanding of the what, and that is the anatomy, the pathology, and still bonus, but a little bit more expected, is that history. You got to have a respect for the history of surgery, all right? That gives you an idea of where we've been, where we're at, and where we should be going, okay? You got to know why you're in the operating room, and you have to know why you're in there at that particular time point, okay? I'll always be asking my senior residents, so why are we doing this operation today? Or why is this urgent or emergent, okay? It's important to know that, because when you're attending, you're going to have to make these decisions. Well, do I do that tonight, or do I do that next week? Do I have the patient follow in clinic, or do I admit them and operate now, okay? And so that why is really important. For the how, now I'm expecting a fairly detailed understanding of that story, okay? Not only the basics, but what are the options? What are the different approaches? So we could do this open, we could do this laparoscopically or thoracoscopically, okay? What are all the different ways that, for example, we could take out an appendix? So, for example, number one is you could take the mesentery with hook electrocautery, and then you could take the appendix with a vessel loop. You could take the mesentery with a stapler and then take the base of the appendix with a stapler. You could take the appendix with an energy device, like a ligature device, and then take the base of the appendix with a stapler. You could have 3 ports, or you could have 2 ports, or you could do a single incision laparoscopic appendectomy. So I expect the senior resident to know all of these different options, and then I expect them to know why they want to do it the way they want to do it. Now, me as a surgeon, I've kind of figured out how I approach an operation. I did that through not only 10 years of training, but doing it all of these different ways that you do in training, and then deciding for myself what I felt was the best approach. I'm also going to expect the senior resident to know, well, what are the technical hurdles? And what am I going to do if I get in trouble? What am I going to do if I get into bleeding? Let's say that you're doing a thoracoscopic lobectomy for a congenital pulmonary airway malformation. You start this thoracoscopically. Well, what happens if you get into bleeding in the PA? Do you have blood in the room? Do you have a venous shadow? Do you have a scalpel ready to go? Do you have a sponge stick? Do you have these kind of backup plans so that if you do get into trouble, you're able to change course and do a safe procedure? You never want to be in a situation where you're not prepared when a case doesn't go as planned. So you want to be thinking about that. And I'll always ask my senior residents, so what are all of these other things that you have to consider for this particular operation? Now, what resources are good for the senior resident? Well, for general surgery, I think Cameron's is a fantastic book. Coming from Johns Hopkins, this is almost a how we do it. I talked about this in my favorite books in surgery, but it's not a book for the intern. It's not really a book for the junior resident. This is a book to get an idea of how a particular institution manages surgical disease. And as the senior resident, it has really nice discussions. There's a really nice dialogue, and that gets you into the mindset of overcoming technical hurdles or having different options when an operation can get complicated and not go as planned. Another great resource is the journal. So you want to be reading the Journal of American College of Surgeons. In pediatric surgery, I'll tell you in a minute, but we read the Journal of Pediatric Surgery and others. So you want to have these other resources that's going to keep you up to date. For the senior resident fellow, they have to now kind of transition past the textbook and start paying attention to what is happening right now and how can I do the safest, highest quality surgery. And so what do I do as a pediatric surgeon preparing for cases? So absolutely, I know the who, all right? I've either met them in the emergency room, or I've met them and their family in the NICU or the PICU, on the ward, or in clinic if it's an outpatient or an elective problem, okay? So I absolutely know the who. I know the what, okay? So after medical school, 10 years of training, I spent a lot of time reading anatomy and pathology. When I'm engaging in an operation that perhaps I don't do very often, I'll review the anatomy. If I'm doing, for example, lobectomies, let's say I'm doing a right middle lobectomy or a right lower lobe lobectomy for a CPAM, I'm always going to review that pulmonary vascular anatomy. Okay, I'm always going to do that the night before and the morning of the operation, because that is a critical point in doing that operation effectively. I'm going to review those imaging. I'm going to have a solid understanding and communication with myself about why. So, yesterday I did a laparoscopic cholecystectomy on a girl with acute cholecystitis. And I felt that, this operation needed to be done yesterday. She was admitted that morning because she was so sick. And I felt that waiting was just going to make that inflammation worse. So understanding why I'm doing that now and not waiting, okay, is really important. After why, for me, kind of before the how, comes with concerns. So what are the patient's concerns? What are the family's concerns? And I take those into account when I'm planning an operation. What is the family worried about? What additional communication or discussion, education do I have to provide as their surgeon to get them and their child through this operation, not only safely, but I want them to be satisfied, and I want them to feel good. I want them to feel good about it. And so the how, so for operations that I do less often, I'll go back, and I'm going to show you some resources in a minute, but I have a thick Evernote notebook, all right? And I've done a video on how to use Evernote effectively, but that's where I'll store my notes for operations that I might not do very often. So for example, the technical subtleties of doing a sacrococcygeal teratoma, or the technical subtleties of a cloacal exstrophy or a cloaca repair. And so the after. So I always have to be thinking about what happens to that patient after the operation. So we talked about the closing of an operation. So for example, how I close a wound. Do I put a drain in? How about that Foley catheter, nasogastric tube? Where are they going to go? NICU, PICU, floor? They can discharge home. But I have to think about, well, when's that follow-up going to be? Do I want to see them in 4 weeks, which might be typical for a laparoscopic appendectomy? Or do they have a wound or a drain in, and I want to see them earlier than that? So I consider the after, and that's really important. So what resources do I use as a pediatric surgeon? Here's an example. So I'll go back, and I still have all of my textbooks. So I'll go through Ashcroft's, and I'll be rereading chapters. In pediatric surgery, we have this amazing resource called Not a Textbook, and that is provided through our APSA membership. Okay, and so that's an amazing kind of up-to-date online resource. I'll be reading the Journal of Pediatric Surgery, so that's my discipline. So I'll be reading that every month, every issue it comes out, so I get a knowledge of where the field's at, what I should be paying attention to. Also, I have that Evernote logo here. So I have a thick resource of Evernote notes that are my own personal notes on all sorts of different operations. So what worked best? What setup worked best? When I do a Kasai for biliary atresia, what are all the things that I need to make sure that that operation goes smooth? And so I have a big group of doctors here, and that's because I'm using my network. If there are new things happening, pediatric surgery is a small field. I'll reach out to friends that are at other institutions, and I'll ask them, hey, so what are you doing? Or is this a new way that you're managing this particular disease? And we'll talk, and that's how I also participate in that constant personal development. So you want to look at your textbooks, yes, but you also want to be reading the journals. I put SAGES up here, so SAGES is a great resource. They have great videos there, and there's a ton of expertise in laparoscopically, minimally invasive surgery there, new approaches. So once you get to be an attending, once you graduate, continuing medical education is important. So use your own notes, use the journals, use online resources, use your network. That's how I prepare for my cases in attending. And so I hope you enjoyed that today, going over how to prepare for a case. A bunch of you asked me if I could kind of talk about that at every level, whether you're a student, intern, junior resident, senior resident fellow, or even an attending. So I had a lot of fun kind of telling you how I do it. The other thing today was talking about a surgery is a story, beginning, a middle, and an end. Try not to think about it in steps. It can get overwhelming trying to memorize all of those steps. If you like what we talked about today, share it with your friend. Make sure to subscribe. Leave a comment. I love engaging with you guys. I love answering your questions. And so you can find me on LinkedIn. You can find me on Twitter. Find me on here on YouTube. Engage in the community. Check out citizensurgeon.com. And as always, stay safe, study hard. I'll see you in the comments.